disease, which is caused by the swelling of the hemorrhoidal veins located in the anal canal, develops based on the degree of swelling and progression, and is classified into different grades. Hemorrhoids are divided into grades 1, 2, 3, and 4. In the first grade, the patient does not notice any changes in their body, except that sometimes they may experience bleeding. This bleeding can occur intermittently, 1 day, 2 days, or 3 days, and is usually a small amount, appearing as drops of blood or sometimes blood that is visible on the stool. This is how the presence of hemorrhoid disease is detected. However, in grade 1 hemorrhoids, the swelling is not significant enough to protrude from the anal opening for the patient to notice. Then, when it reaches grade 2, the swelling becomes large enough that during bowel movements, it protrudes from the anal canal, and the patient notices what is commonly referred to as a lump or a small mass of tissue in the anal area. This is considered grade 2, which can therefore be accompanied by bleeding and is also associated with the protrusion of the hemorrhoidal lump. But usually, at the end of the bowel movement, it returns to its original place, and the patient notices this. There isn't any other specific disease. Grade 3 hemorrhoids are similar to grade 2, but in this case, the hemorrhoidal lump is such that when it protrudes from the anal opening, the patient has to manually push it back into place. And in grade 4, it's when those significant hemorrhoidal lumps, whether 1, 2, or even more than that, are permanently located outside the anal canal, causing considerable discomfort. Overall, the hemorrhoidal plexus, or more specifically, the hemorrhoidal venous network, is located under this mucosa in the anal canal at the 3, 7, and 11 o'clock positions. There is one on the left side and 2 on the right side of the patient. This condition, when it occurs, is not accompanied by pain and does not cause any particular problems. If there is any pain, it is very mild. Sometimes the patient complains of a burning sensation or itching, which is due to secretions around the anal area. In the early stages, when it is present, it does not require any specific treatment. When it is at grade 1 and only accompanied by bleeding, there really is no special treatment. There is no specific medication for it, and the medications that are mentioned are only for controlling some of the symptoms of the disease. The only thing the patient should do is to avoid constipation and not spend a long time in the bathroom during bowel movements. As for other specific medications that might be prescribed, these are usually substances known as laxatives or materials that help soften the stool. These are called laxatives, but not the types that cause diarrhea. Rather, the ones that simply make the stool softer are recommended. This is enough to reduce the pressure on the hemorrhoidal veins or to decrease the strain on those hemorrhoidal sacs. Once this stage has passed and the disease has progressed further, if in grade 1 the bleeding continues for a long time or becomes excessive, then interventional procedures or treatments may be needed. In grade 2 as well, if necessary, interventional treatments may be required, especially if the bleeding is heavy, persistent, or if the prolapse is causing the patient concern. In these two stages, grade 1 and grade 2, most treatments are conservative, and management can often continue simply with fiber intake and avoiding constipation. patient comes in complaining of bleeding, if it is grade 1 or 2, conservative treatment is usually sufficient, such as prescribing fiber and advising the patient to consume fiber-rich foods to prevent constipation. The use of common medications generally does not have much of a role. However, if in those same grade 1 or 2 cases the bleeding is heavy, persistent, or the prolapse is bothering the patient, then interventional treatment is needed. In grades 3 and 4, some form of interventional treatment is usually required as well. One issue that exists is whether we should immediately perform surgery on a patient with hemorrhoids just because they have hemorrhoids. As much as possible, we try to relieve the patient with simpler, less invasive, and outpatient treatments. There are a number of patients who need these treatments, but then we realize that they haven't responded, for example, to non-invasive treatments. We can later consider them candidates for invasive treatments. So, what are invasive treatments? These are medical treatments in which, in fact, we carefully treat the patient using a series of therapeutic injections or by employing certain specialized instruments. Hemorrhoid patients especially are very afraid of surgical treatment for hemorrhoids because the standard, and in fact the gold standard treatment for hemorrhoids, is to go in and remove the hemorrhoidal mass, which we call a hemorrhoidectomy. But it is very painful and has many complications. Therefore, we try to first use simpler, less invasive treatments such as sclerotherapy, infrared therapy, electrotherapy, or hemorapy. Each of these methods has its own specific place. For example, sclerotherapy involves injecting a substance into the hemorrhoidal mass, which can have its own specific complications and cause inflammation. And for this reason, it has been almost phased out over the years. In the case of infrared, which is used, the electrode or the emitter is placed on the hemorrhoidal mass, and about 3 millimeters of tissue around and in depth is destroyed. Therefore, a large hemorrhoidal mass must be treated with the emitter in different areas, and this method is not particularly effective. Another treatment is the use of elastic band ligation. Elastic band ligation is only used for hemorrhoids that are located above the dentate line. When we carefully use this particular method, it effectively captures a few precious millimeters of the hemorrhoidal bundle within the elastic band itself. If the hemorrhoid has unfortunately extended below the dentate line and the surrounding skin has become significantly involved, applying the elastic band can be an extremely painful experience for the patient. The band can only effectively treat a few millimeters of the hemorrhoidal bundle, and after a few days, the treated area gradually becomes ischemic and eventually disappears completely. Therefore, several individual elastic bands may need to be carefully used to achieve the desired therapeutic effect. On the other hand, sometimes this procedure can potentially cause bleeding or even a serious infection, which can be quite problematic and require further medical attention. Another Another much simpler and more convenient intervention is the innovative use of electrotherapy or direct current electricity, which is also widely known as hemorrapy. In this particular method, a precise direct current electricity is carefully applied through a specialized electrode directly into the hemorrhoidal bundle, causing it to be effectively destroyed. In electrotherapy for hemorrhoids, we specifically use a sophisticated device that efficiently converts alternating current electricity to direct current and then applies it in a very specific and controlled way. The electrode is gently inserted into the hemorrhoidal bundle, and within a few short minutes, noticeable changes begin to occur within the bundle, ultimately leading to its complete destruction. When we carefully place the negative electrode inside the hemorrhoidal bundle, a comfortable pad is securely attached to the patient's thigh to ensure proper and consistent electrical contact, and then the current is carefully activated. When the electrical current flows, it initiates significant changes in the local blood system, producing various gases from the breakdown of water and other important changes in the surrounding tissue, all of which collectively increase the overall volume of the hemorrhoidal bundle. After the current is carefully stopped, usually about 2.5 minutes for grade 1 hemorrhoids, 3 to 3.5 minutes for grade 2, and up to 4.5 minutes for grade 3. These crucial changes occur and the treatment is then considered complete. The patient is then safely released and the enlarged bundle gradually and progressively shrinks over time. Usually after a period of 10 days to 2 weeks, there is absolutely no trace of the bundle left whatsoever. This particular method is remarkably painless, does not require any special anesthesia, is very quick. The entire treatment is typically completed in about a single minute and boasts a very high success rate, approximately 98% for grade 1, 96% for grade 2, and 92 to 94% for grade 3. We usually do not use this specific method for grade 4 hemorrhoids because when the electrode is carefully placed in a grade 4 bundle, the gases produced significantly increase the volume of the bundle, which is already located outside the anus, and this noticeable enlargement can be quite concerning and uncomfortable for the patient. Additionally, sometimes the entire process can be irritating and bothersome. As a result, we use this method for grades 1, 2, and 3, where it is very effective. Now, should this be done under anesthesia or local numbing? The electrotherapy device, or this same Hemorapy device, comes in versions up to 16 milliamps, and there are also versions up to 30 milliamps. For so-called grade 1, 2, and 3 piles, we can use the 16 milliamp setting without anesthesia or numbing. However, if we want to speed up our work, or if the piles are actually larger, or if we want to perform the procedure using anesthesia or numbing, then we can use the device at up to 30 milliamps. In intermediate grades, we can use either of these settings, whether 30 milliamps or up to 16 milliamps. The only thing that changes is the duration. If we use up to 16 milliamps, usually the time required for grades 1, 2, and 3 is longer, and it may take more time. We might even have to use this system or method once or twice to complete the treatment of the hemorrhoidal pile. But when we use the 30 milliampere setting, that is when we use the 30 milliampere type and apply 30 milliamps to the hemorrhoidal pile and maintain a steady 30 milliampere current, the treatment time required is shorter. As I mentioned, for grade 1, it takes about 2.5 minutes. For grade 2, about 3 to 3.5 minutes. And for grade 3, about 3.5 to 4 minutes. The results are also very good, provided that the electrode is properly placed and positioned correctly on the pile. After the procedure, the patient does not experience any particular pain. We can use up to 30 milliamps with anesthesia, or more specifically with spinal anesthesia, and the patient is comfortable, though the treatment may take a few minutes longer. However, if we want to use the same 30 milliamps or the 30 milliampere current without general anesthesia or spinal anesthesia, we can use local anesthesia by injecting lidocaine or any combination we determine, such as a mix of lidocaine and procaine. We can inject it at the 2 and 10 o'clock positions around the anal canal or directly around the anus. With any of these current settings, we can proceed. That is, once we've injected the anesthetic, we can treat the patient using the 30 milliampere current. Surgical intervention procedures for hemorrhoid disease are typically and usually employed for patients who experience significant and debilitating complications or whose frequent and bothersome prolapse causes them persistent and ongoing problems. Surgical procedures are considered the first and standard method, so to speak. The procedure we call hemorrhoidectomy means removing the hemorrhoid that is problematic. For years now, efforts have been made to change this method and adopt simpler approaches. In hemorrhoidectomy, the hemorrhoidal tissue is removed, and depending on the technique and method, that area is either left open or, in some cases, not. However, the base part, which is essentially the root and is just the root, must definitely be closed to prevent bleeding. There are other methods that use devices for treating hemorrhoids, such as PPH. With the use of the PPH stapler, we actually go to a higher area to place the hemorrhoidal tissue within the jaws of the PPH device. We position the mucosa in such a way that it enters the jaws of the PPH, and about 2 to 3 centimeters of mucosa above the dentate line above the hemorrhoidal pads is actually removed. As a result, the blood supply to the hemorrhoidal pads is disrupted, and since the mucosa is removed, the hemorrhoidal pads are pulled back to their original position, which causes them to shrink and gradually become smaller, leading to the treatment of hemorrhoids. Other devices can also be used, such as lasers, which are recommended and used. Each of these methods requires specific devices, consumables, and the main system itself, making them costly. When I compare this to hemorrhoid electrotherapy, which is a basic method and not expensive, it also does not require consumables. In fact, we use an anoscope and an electrode, and it does not require any special consumables and is not costly. On the other hand, with any of the other methods we use, there is some pain, more or less, but there is pain. Whereas with electrotherapy, there is no significant pain, and so far, we have not encountered any particular complications with the electrotherapy method.